So hearty good afternoon to one and all. Welcome to our second session. Today we are having a topic on introduction to pain. It will be taken by Dr. Anne. So we can start with ma'am's presentation. We can have it for around 40 to 45 minutes followed by 50 minutes of discussion. By 4 we can have our case presentation followed by its discussion. By 4:30 we can wind up our session. Thank you all for joining in. Over to Dr. Sridevi.
Raju, am I audible?
Yes. So I request
all the videos I feel.
yes.
Yeah, some of the microphones are unmuted.
So I request all to remain unmuted only. I'm sorry, muted only. So even though we are trying to mute you, please stay muted. You will be able to hear us.
Should we start?
Yes, ma'am.
Good evening, everyone. Thank you for logging in early. And I'm glad to welcome, I'm actually excited to welcome my dear friend, Dr. Anne. She's a professor in University of Iowa. She's been visiting us as a volunteer, spending few months from her schedule from Iowa in a very different culture and setting. She visits us every year since last 5 years, and we met 5 years back because I just had my daughter that time when we met first time.
Yeah.
So it's so she visits us a few months every year. She has undertaken already a lot of work for us, trained us, taught us a lot of things. So glad to have you for this session, and welcome to EcoSession.
Thank you so much. What a pleasure to look at all your faces, and I look forward to this lecture. So we'll go ahead and get started. I have worn many hats. Let me just stop for a moment. My English is American English. I'm from Iowa, which is the center of the United States. If you have trouble with my English, please just put your hand up, whoops, so that I can slow down or explain things better. So far, am I understandable? Thumbs up? Not? Okay, just let us know if you're having trouble. For over 30 years, I have been a palliative care physician and a hospice physician. I learned what I learned mostly by seeing patients. Sometimes I travel very lonely roads in Iowa to see patients with very complex pain, often seeing them in the middle of the night. I'd like to share the next 45 minutes with you to explain some things that I wish I had known 30 years ago. So I'm hoping that you don't have to spend 30 years learning what I've learned. I am at the University of Iowa, but I am also at the VA Medical Center in Iowa City. Today, by the end of this 40 minutes, I hope you will be comfortable with describing pain, listening carefully to hear what patients are telling us about their pain, because they will give us clues about where their pain is coming from. I'm going to give you words to describe the pain, but I want you to look at the pain not as just a physical phenomenon, but also a social, relational, total pain. So, and I think it's also important before we go forward is to talk about acute and chronic pain and how they can be different. So, like I say, I think at the end of this time, I hope you have a scheme, protocol for assessing pain that is different than what we have been doing, which is just giving pain a number. We want a better descriptor of pain. So let's start with a patient that sounds very much like a patient that I had probably about 20 years ago. Shwana Prabha, I should have gotten the pronunciation better before I started, is 32 years old. And she unfortunately has advanced cancer of the breast, stage 4, and she's in pain. She is a wife and a mother of 2, and her pain does not seem to respond very well to medicines. In fact, sometimes she doesn't even take the medicines. She has poor adherence to treatment. I should have warned you that I'm going to ask you to participate. What kind of pain can you identify for this patient? What kind of pain do you think she has? Just raise your hand and we'll unmute you if you have trouble with the technical aspects. Can you think of any kind of pain that she might be experiencing?
Yes,
Dr.
Dr.
Prima?
Somatic pain. She has somatic pain and mental pain, both.
Okay, so somatic pain, that's a word that, what does somatic pain mean?
Pain from the malignant breast tissue.
Pain from the breast tissue, and then also emotional pain. Correct. What else?
Any more answers? You can just raise your hands. We will unmute you.
Dr. Prima?
It is also spiritual. She must be blaming God for what is happening to her. Young woman with a child.
Correct. And did you say spiritual?
Yes.
Yes. I
There is
couldn't
one
agree.
more, someone has raised hand, Maheshwari.
Okay.
Yeah, I think she's a mother of 2, so I think it's pain out of fear. Even she's fearful, like what will happen to my kids if I'm no more. So it's out of fear.
Yes, I think fear, spiritual pain. Dr. Prima suggested spiritual pain. And I think we sometimes, as physicians, I know there's a high group of physicians from the Catholic Health Association of Iowa, but sometimes we worry about addressing the spiritual pain. Why the spiritual pain, which is why me? Why did God choose me? What is my role in the universe if this terrible thing has come upon me? Absolutely. I think we can also imagine that she has lost intimacy with her husband. That often happens when women have breast cancer, especially if there's a mastectomy. So she's got relational pain, social pain, spiritual pain, as well as physical pain. And we're going to address each of those today and talk about how we might address each of those different kinds of pain. And the reason that this is important is that if we treat all pain as if it's physical pain, we will maybe give medications to this patient, but we won't treat the underlying social, relational, grief, spiritual pain. These other non-physical pains amplify or make bigger physical pain. So unless we address them, we are not going to help her alleviate her pain. Okay, let's go on. So as you might imagine, pain is a sensory of the senses and emotional experience. And I think I'll speak for physicians in the US. We forget that there's an emotional covering to all pain. And if we don't address it, we can't get pain under better treatment. Thank you. The experience varies from person to person and from time to time. And patients will become accustomed to their pain and be able to go about their daily lives, but this does not mean that they're not in pain. It means that they are attempting to adjust to their everyday life. And finally, important palliative care principle is that we believe patients when they describe their pain. It doesn't mean that we give them pain medicines, but we have to believe their experience. If we don't, we won't be successful in treating their pain. Think back to the last pain that you have had. Was there an emotional component? I'm just making, and if somebody is with you here in on your echo, talk to them about it. You can stay muted and talk to other person, or just think yourself, when's the last time I was in pain, and what was the emotional experience that I had? This is really hard to share, but is there anybody who's had a pain that had an emotional component to it that you'd be willing to share?
Dr. Maheshwari? Ma'am, can you unmute?
Hello. Yeah. Yeah. Able to hear me?
Yes.
Yeah.
Yes.
Actually, just maybe about a month back, night around 11 o'clock, because of factors of gastrointestinal upset, but I got left shoulder pain, and just before a week of that pain, then one of my technical staff, she passed away because of MI. So in the night at 12 o'clock, I thought, oh, I might get left shoulder pain, and I was working out also at the time. But even then, I know that, but still, my mind was like so emotional, telling that I'm going to die. So it's really out of fear. Then for next 1 hour, I couldn't sleep, and I was calling to my friends, family, telling that I'm having mild pain, nothing to worry, but still, I was emotionally disturbed. A fear of death.
I think thank you very much for sharing. It's often hard to get people to share on echo. I think that's a brilliant example of how your worry and fear, prompted by an experience in your life, a recent difficult experience, has made that shoulder pain that you have a far bigger emotional experience than it might have been otherwise. Is there anybody else who's had something similar? That's fine. I thought it would be helpful for me to share a pain experience that also was amplified by worry. It's a short story and it came out fine, but I fell while trekking in the Western Ghats, and I had wrist pain, and I couldn't decide whether I should go and get an x-ray or not, and then I'm back and forth, and the anxiety was terrible because I worried that if I had an x-ray, I got myself completely anxious until I found a physiatrist who looked at it and he said, Anne, you're getting all anxious about nothing. Nothing is wrong. And instantly my pain was gone. So it made me realize that it was more an emotional experience than a sensory experience. I don't give this example to make light of pain. I mostly want you to see that if we don't meet the emotional component, we won't solve discomfort. Okay, next. So the person who made the most important, changed our thinking the most is Cicely Saunders. She is a person of great renown. She died not too long ago. She is born and worked in London and started St. Christopher's Hospice in London. She is herself was a multidisciplinary team. She was a nurse, a social worker, and a physician, trained as all of those. So not a big surprise that when she talks about total pain, she understands that there's the physical component, which feels as if it's localized pain. There's the spiritual component, which is why me? Why have I been chosen for this? What's the meaning of my life? Emotional pain, which we can also talk about as grief. And social pain, losing our role in society is often a source of great sadness and discomfort. And it would be remiss of me to say that there isn't some influence of finances when patients are having social pain. Often they lose their ability to make money. Sometimes here in India, we see that the children no longer are able to go to school because of illness. These are important. And at all times, our objective isn't to wipe out pain, but it's to improve the quality of life, and only when we address these 4 pains. We have been talking about total pain for a long time. And let me give a little bit of emphasis about why this is so important. When Cicely Saunders had patients in her hospice with very advanced cancer, her doses of morphine were quite low. And the reason for that was not because she was not interested in treating the pain, but rather because she handled all the other aspects of the discomfort through listening, counseling, addressing the fears and issues that a patient had, sometimes handling the finances that people brought anxiety to them. So important that we do all of this, because it will mean that our doses of medications are less, because we've addressed all the amplifiers of pain. Am I clear? Are people understanding my English? Can I see thumbs up or thumbs sideways? Are we doing okay? Okay, all right. So total pain, and interestingly enough, there was just a study from MD Anderson Cancer Center. This is a very big cancer center in Houston, Texas, and they were able to show that when patients had a pain crisis and required to be admitted, they could come into the palliative care center, and they didn't change the medications, they just addressed the social, financial, emotional, and spiritual pain. And guess what happened? Their pain was reduced enough to be discharged without any change in the medications. I have to say that this has, both Cicely Saunders and this study have altered my practice dramatically. And I'm happy to send that article out to everybody if that would be helpful. Okay, next slide. Okay. So let's talk about the types of pain. These terms are not always clear for me, so I'd like to make them as clear as possible for you. Nociceptive refers to the kind of pain that stimulate receptors that are then stimulated and send signals to the brain. Those nociceptive receptors might be in the skin when you have a cut, or they might be in your bones when you've broken your bones, they might be in your knee joint, but they send signals because of inflammation and irritation, they send signals to the brain. The somatic means that it's in the joint, skin, bone, and muscles. And all this refers to is that there are nociceptive receptors that have been stimulated. And we'll see a picture, a little bit of a cartoon in a minute. In contrast, visceral nociceptive pain is from the hollow organs. So I'm going to just ask, sorry if I say your name incorrectly, Dr. Maheshwari, sorry. What kind of pain were you worried about that night? What would you say?
Dr. Maheshwari, are you there? Can you unmute from your end and answer? Doctor, your words are not clear. Doctor, we can't.
Okay, we'll come back to you. Can anybody give me an example of a pain that they've recently had that was somatic?
Doctor, we can't hear you.
Leg pain, that is a somatic pain. Back pain.
So Dr. Kavitha, can you give me an example of somatic pain?
Back pain, sciatica. Back pain is a somatic pain.
Okay, so back pain from the joints of the back can be a somatic pain. What about a visceral pain? Anybody have any ideas where we get visceral pain?
Abdominal.
Dr. Kavita? Ma'am, can you unmute from your end and speak? We can't hear you. Yes, doctor.
Abdominal colic.
Abdominal colic. So when you get air trapping in your abdomen, that is visceral pain. It's a little more difficult. In contrast, when you break a finger, you have somatic pain and you can point to it. In contrast, visceral pain is more diffuse. You can point to the entire abdomen. Menstrual cramps are a great example of visceral pain. It's that hollow organ that has cramping, and we'll talk about that in a minute. Neuropathic pain, however, is initiated in the nervous system, sometimes due to irritation of nerves, but sometimes without any precipitating factor whatsoever. We also, I just want to drive home very clearly that psychological or emotional pain, including anxiety, can amplify all other kinds of pain. And if we need a systematic way to identify anxiety, because it needs to be treated in order to adequately treat pain. When I address spiritual pain, it's usually sitting down with the patient, asking them what connects them to the world, what is their legacy, what's most important to them. It's a conversation that I have in my VA hospital a lot. Sometimes, oh, you just gave away my card. Sometimes in the VA hospital, veterans who have been in wars and have done, in the name of a war, have done dreadful things, are suffering a great deal, and they need to ask for forgiveness for what has happened. You also have social pain, and I think our young 32-year-old wife and mother of two is already losing relationships that she finds important. People who are working often find that things are more difficult because they're not working. In most cases, patients have mixtures of kinds of pain. Okay, let's go on. So what do we need? What's most important for a pain assessment? I think my colleague gave it away to you, so we're going to tell you the most important tool for a pain assessment is, go ahead, the chair. What do you do with the chair?
Comfortably.
I'm sorry, what did you say?
Dr. Kavita? Ma'am, can you unmute and speak? Dr. Purita?
Yeah, sit and listen to the patient patiently.
Yes. I have to say that it makes a big difference if you sit down instead of standing up. I won't violate my social space with my colleague. If you stand up, the quality of your interview is not good. If you sit down, you say, I'm here to listen. Your body says, I'm here to listen. Sitting down will allow you to hear about that patient's pain and hear what's most important to them. So you might find it amusing, but if on rounds at my hospital, if one of the residents or even if one of the staff cardiologists tries to have a conference with a patient while standing, I go and find a chair and I bring it in and I invite them to sit down. It's a little embarrassing, but you might not notice that I have gray hair, so I'm allowed to do all sorts of things at my hospital that other people can't do. Everybody needs to sit down. We don't want people standing and making the situation uncomfortable. There are even 2 physicians at my former hospital, University of Iowa, who carry a chair with them. That's how important they think it is. Now, it's also called a golf chair. I don't play golf, so I don't know what you would do with a golf chair, but they carry it around with them. So I think I've made my point. It's a little silly, but I think what's most important for a pain assessment is the chair. Okay. So often we physicians want to do most of the talking. We talk, we ask questions, the patient answers, and I prefer to say, tell me about the pain, and then I try to listen for all these other factors. I try to listen for what the quality of the pain is. Is it sharp, shooting, pricking, throbbing? Is it, did it start with, maybe it started after a fall in a hike in the mountains? Maybe it goes somewhere. I think somebody mentioned sciatica, which means that the pain maybe starts in the buttocks and goes down the leg. What makes it better and what makes it worse? When does it happen? And most important is, what are they unable to do because of the pain? Are they able to sleep? Are they able to work? Are they able to play with their 2 young children? These are the things that you're listening for. And most of the time when I do a pain assessment, I try to say, tell me about the pain, and then I do the equivalent. In the US, I would say, oh, 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 oh. I just keep them going, talking and talking and talking about their pain. To be truthful, even if they do 70% of the talking and I do 30% of the talking, I find that this goes quite a bit faster if I don't keep interrupting. I get a clear sense of what the pain is like. Then I ask, what medications have they taken? I want to know what medications they're taking that might be over the counter. Here in Iowa, Where I am from, there's a strong Ayurvedic tradition. That might amuse some of you. Some of them are taking Ayurvedic medicines. Some of them are taking over-the-counter. So it's important, if they're taking paracetamol, how long does that last? If they're taking ibuprofen, how long does that last? And if they're taking morphine, if you are in an environment where morphine is available, how long does it last? Does it give them any pain relief? It's important to recognize that morphine does not, you will get this in later segments, morphine will not treat all pain. So important for us to recognize when they take morphine and they get no pain relief whatsoever, that's an critical thing for us to know, because that helps us understand what kind of pain it might be. So I'm take a lot of notes about what kind of medications they take and what helps. I often ask, sometimes people don't take morphine, and I inquire why. Sometimes it's fear of addiction, or they're scared of morphine, or they associate, in the US, they might associate morphine with the very end of life. I need to deal with all of those fears and misconceptions. Okay, I think we're gonna, here's I think what will be a helpful slide when we send these along to you, that if the patient has somatic pain, they can usually point with a single finger where their pain is, and it might be lots of different kinds of descriptors, but it's well localized. In contrast, when they have visceral pain and they might have other symptoms. This is the pain of a heart attack is a visceral kind of pain. Frequently it's referred to different kinds of places, to the shoulder, to the arm. Sometimes women have completely different kinds of discomfort. Often there are sympathetic symptoms or parasympathetic symptoms of nausea and vomiting. So really important to recognize that visceral pain is poorly localized, and malignant bowel obstruction, intestinal colic, as one of you has pointed out, menstrual symptoms, or the enlargement of the liver from cancer can often cause visceral symptoms. And then neuropathic pain is often damage to the nerve. We're increasingly recognizing that bone pain has neuropathic components too as well, and might do better with neuropathic agents. And people usually describe it as burning, electric, shooting, stabbing, tingling, and in many cases, especially if a cancer has invaded the brachial plexus, they describe the pain as unremitting. 10 out of 10. In fact, most of the time they say, no, it's 15 out of 10. It's off the scale awful, and it's persistent. The patients who describe neuropathic pain are among the most miserable people in pain that I've ever met. I often see patients with neuropathic pain who have ischemic pain. They don't have enough blood supply to their legs, and they have that kind of pain with ulcers. Okay, so now I'm hoping that you see that you'll get clues if you listen closely to the patients about what kind of pain they have if you listen. And I'm sure all of you are great listeners. Unfortunately, we train physicians to interrupt within 10 to 15 seconds of a patient starting to talk. So I encourage you to use what I call the BRODERICK 30-70 rule. Let them do 70% of the talking, and we do 30% or less. Okay. So recognizing that people don't take their medicines for a variety of reasons. Sometimes they're fearful of the medications. Sometimes there are clear financial reasons that people simply cannot take the medications. That's as true. That's true for us in the US, and it is also true here. But there also may be an emotional reason that they don't want to take the medications or look at a clock because it reminds them that they might be dying. Over my career, I think we've come to realize that persistent or chronic pain that has lasted over 3 months, is a completely different phenomenon or animal than acute pain. The persistent or chronic pain may have lost, and that's simply defined as over 3 months. Whatever injury started it may have been long gone, and the patient might not be able to localize very well. And there's good reason for that. And that is, as a patient continues to have the stimulus that is constant, the body starts recruiting both peripheral receptors and receptors in the spinal cord that increase that pain. So suddenly we're feeling the discomfort from areas where the injury did not even take place. Let me just, right, can I point with you? Sorry. So remember that, let me get this mouse to behave itself. Remember that I said that nociceptive pain is any pain where the peripheral nerves are stimulated. So if the stimulation continues, then nociceptors that are nearby will also be recruited and amplify the pain. Why did the body do this? The reason the body did this is that if your finger is touching a hot stove, they want you to get your fingers off the stove. They want you to remove your hand and protect yourself. So more and more receptors get recruited, in large part to get your hand away from the point of injury. I'm not probably, this is probably not new, but it explains why we have sometimes have chronic pain long after the injury is over. In addition to recruiting peripheral nerve nociceptors, we also recruit, and I know the anesthesiologists know this, we also recruit new spinal segments, both caudal and distal, to the dorsal horn. So we also have increase and recruitment of pain sites within the central nervous system. If we act quickly with prostaglandin inhibitors, we might decrease the pain and the pain-producing substances which amplify the pain, which is why I think it's one of Dr. Rajagopal's primary teaching to address pain early. That doesn't mean with opioids, not with morphine necessarily, but to address it early through non-pharmacologic measures and step 1 pharmacologic measures. And with time, there is what is called wind-up, which is an NMDA-mediated central sensitization, which worsens pain as well. And it can be inhibited by NMDA antagonists. This For the anesthesiologists in the group, you know that ketamine is an NMDA antagonist. Methadone is which is now legal in India, is also an NMDA antagonist. So when people have persistent pain, I often suggest that we try a persistent or chronic pain, that we try methadone, because this medication may reduce tolerance and may reduce this central windup. That's for another lecture that's coming up for you. I just want to give you a little bit of a hint of introduction to pain. So I think what we have learned is that treating pain early with a variety of non-pharmacologic and pharmacologic measures is good. Recognizing the non-physical amplifiers of pain is always good. And in continuous pain, that the analgesic should be given continuously in order to quiet these natural tendencies of the body to amplify pain, to really to get our attention, to get away from the noxious stimuli. One of the most interesting parts of going and dealing with veterans, many of whom have seen combat, is they recognize people who are being genuine and people who are being not genuine. Convey empathy. The empathy is trying to walk shoulder to shoulder with your patient to solve their pain issue. We can't solve everybody's pain issue, but if your body language, your sitting down in the room conveys that you care for them, their pain, their sense of being heard, sometimes for the first time, will make a big difference in their discomfort. We often see after palliative care sees a patient in the US setting, that the pain is diminished simply because we recognize that they're in pain. You seem to be in a lot of pain. We're just naming it. This actually helps quite a bit. So back to our patient, recognizing that she has many sources of pain. Certainly she has physical pain. We're not denying that. But we do need to recognize that her relationships have been crushed with this diagnosis, and the concern that she's not going to be around to see her two children grow to adulthood, and recognize that something might be causing her not to take treatments that could be helpful. So I'm going to stop there and I'll let Sri Devi entertain the questions.
Thank you, Anne, for your session on pain, pathophysiology, assessment, and types of pain. We would like to hear from the participants. Is there any areas that you need more clarity, or is there any experience that you want to share with us? Raju, is there anyone raising hand? I can't see everyone. Am I audible?
Yes, you are.
You.
I thought it's because of that I'm not heard properly. No one is responding.
We can hear you, but we cannot see you.
Okay, I think I'm sitting very opposite to the light there.
You're visible, but there are too many of us. I think that's part of the problem.
So any questions? You can just raise your hands. Dr.
Yes,
Prem?
Sister Teresa.
We can't hear you. Wait.
Sister Levita?
No, no, no.
No. Okay. Dr. Prema?
I was just saying, no, say, even though we sit there, the patient sometimes takes time. We have to just be with them. We cannot do the initiate the talking unless the patient also feels comfortable to share her pain. Sometimes, silently sitting, she may not be in a market, but she may not experience that closeness immediately.
It was a
Did you
little
understand
difficult. Yeah, it was a little difficult to it wasn't as audible. What I heard you say is that sometimes it's difficult to have a patient trust you maybe on the first visit.
Yes,
With
correct.
all those, that's absolutely. It will take a team to develop that trust. And while you can try to fully understand that person on a first visit, it will take multiple visits for you to completely address all the different kinds of pain. This is why we like to say that palliative care is a team sport. You need a social worker who addresses things easily, more differently, a nurse who may make the patient more comfortable. I'm going to say something that might sound very unusual to the Indian audience, but what we also noticed is that the housekeepers that were cleaning the room often elicited more information from the patient than the physician could. People are comfortable with different members of the team. So important that it's over time. You're absolutely right that this can't happen always on the first visit.
I totally agree to Dr. Ann's comment on them sharing the pain with the physicians. They're not expecting us to ask beyond the physical pain. So even if you try to ask more, they may be slightly reluctant. They may be thinking why this doctor is really strange, because no one else have asked them questions which is not related to their physical issues. So they mostly share their problems with the nurses or with the housekeeping staff, where they have their small talks. Then it comes out like children abandoned, and this is not the scenario that I have at home. So then that is how we get information that what are the non-physical part of pain that they are going through. I would like to hear your comments on the need to treat pain early, because very commonly doctors also tell that try to bear maximum pain so that the medicines are not going to be useless. If you start taking medicines now, you may run out of options when you actually need pain management. So uh, these are the usually told comments by the physician. So what is your say about it? Why should we treat pain early? Is that really important to treat pain early after hearing this session, or any practice points that you want to share? Okay, is it needed to treat pain early? Do you think it is necessary to treat pain early? Or should we wait to reach the threshold where the pain becomes unbearable and then start treating?
Dr. Ajaya?
Hear me? Hello?
Yes, we can hear you.
Hello?
Yes, ma'am, we can hear you. You can speak.
I think if it disturbs her sleep or her daily activities, definitely she has to take tablets, medicines for pain. That's what I feel.
Yes, thank you, Sister Ajaya. So you feel that if it is disturbing her sleep or daily activities, we should start giving medications early, pain medication.
Dr. Prema?
Anyone else on
Yeah,
this?
I feel that the passion that is one step towards gaining our confidence. Because
Doctor,
earlier you said,
we can't hear you clearly. Can you speak through your microphone?
okay. I said that was one step towards building a relationship because we said earlier that we have to believe in her pain. If we just pass it off and say, okay, you can bear with it, that is one way that she can express her different kinds of pain, bodily pain. Maybe special, maybe emotional, but it is expressed in physical pain. So maybe treating and animating that pain would give it a more, build up more that confidence, relationship between the patient and the doctor. I don't know if I was clear. Was I clear?
I lost her in the towards the end, but I understand when you start treating pain early, it's good for building a rapport or
Yeah.
relationship with the patient,
Yes.
and they may
Yes.
start trusting you, thinking that this doctor is believing.
Because we have to believe in her pain. That's all that we believe, that we understand that she is suffering. All the other pains also will express in a somatic form. So that we're caring for her would happen.
Believe in the patient when he or she is in pain.
Yeah, believing the patient, what she says. So that is
To all others in the group, how easy it is to believe the patient when they say they have pain. Do you find it easy?
One must, because there is recruitment, because it was previously said that there was recruitment and sensitization of nociceptors, you have to start the treatment of pain early. Otherwise, there will be, by increasing time, there will be more receptors will be sensitized. The area of receptors will be sensitized. So in somatic pain and the segment of brain is also increasing, we have to start the treatment early. That is another point told by the madam.
Thank you so much, Dr. Kavita. So, Anne, you can be relieved that your American English is well conveyed.
Yeah,
Now we
okay, thank you.
understand why the pain is why should we treat the pain early?
Okay.
Because of the recruitment and increase in area of pain. Raju, I think there are a lot of people unmuted, and I can hear a lot of noises from others.
Yes, ma'am. So, Dr. Maheshwari, you can speak now, ma'am.
Yeah, hello.
Yes, we can hear you.
Especially in patient with psychosomatic pain, like especially a patient with hypochondriac pain, what we can do. At times it becomes difficult to decide whether it's really due to hypochondriac or it's really like a patient is suffering from pain.
Really good question, and I would like to give this question to Dr. Anne.
Oh, okay. Well done.
Okay,
I
thank you.
think, yes, thank you for the question, because when somebody reports pain and you as the physician believe that there's no physical basis to the pain, then it's our responsibility to explore why that person is reporting pain. And I think it requires, I would say, the assessment does not change. What makes it better? What's the quality? What makes it better? What makes it worse? What's the setting? What medicines make things better? In my mind, it is critical that we go through the assessment just as honestly as we would if we thought that it was somebody very trustworthy. And I say that for two reasons. One is if you take that person seriously, virtually by taking them seriously, you may alleviate their pain. You may not abandon them. Whatever pain is not physical, you may better manage. But I think the other thing is that we need to approach people that we believe have hypochondriasis with a little humility, because it could be that they have something very, very critical. The emergency rooms are full of women who came with heart attacks, but because they didn't have heart attacks that looked like men's heart attacks, they were sent away and sent home. So it's important that we have an ounce of humility when we address somebody with that we believe is inflating their pain. But we should also recognize that there is a social, psychological, and spiritual underpinning to that pain. In my world, I have found that every time I take that person seriously, I have diminished their pain because some component of their pain is being not taken care and not being taken seriously. I hope that's helpful, but yeah, that's, I feel very strongly about taking every patient freshly, looking at them freshly.
Yeah. Thank you, Dr. Ann, for that. It's a really tricky question, and it's not uncommon to get patients like that, especially when it comes to chronic pain. Many patients present with this kind of pain, where we feel that they may not be in pain. So, as Dr. Ann was telling, the assessment remains the same. Being non-judgmental is the key to believe this kind of patients. They may not be needing the medications per se, but they may need, when we talk about the total pain, they may need the other elements to be taken care of than the physical element. So again, it's a pain, not just attention drawing or anything else. We have to make ourselves believe that they are in pain. May not be physical, but any type of pain. Any last question from the participants before the case proceeds?
You can either raise your hand or unmute yourself and speak.
Or I myself will bring out the unpleasant questions. How comfortable are you to sit with the patient, sit and talk to the patient? Currently, I'm running a training program here. So the first day onwards, the message I pass to them is to sit and talk. So, like Dr. Ann said, I move around with a plastic stool, go behind them, and just from the back is like sit. Some doctors, after 2 days, they literally told me that, see, I'm really uncomfortable to sit and talk. Please don't push me more. So they don't feel, I think we want to feel that power ratio when we are standing and the patient is lying down and talking. But those who have practiced that sitting, they told that they didn't have to ask anything. The patient himself brought out all the stories that they have been going through. Everything. They told the pain assessment was so easy because they explained it so well, because they felt that this doctor has time to talk to this patient. And just today morning, one patient, I was rushing for the exam to be conducted, but I just wanted to ask the patient, how are you in the morning? So the moment I entered and I asked, how are you, uncle? Then he told, do you have 5 minutes? Are you busy? That was the first question, because I did not sit. So you're literally conveying, when you are not sitting, that I'm rushing for something else, I don't have time. Because he noticed that every other day I sit and talk, today I did not sit. So he's like, are you busy? Do you have 5 minutes to sit and talk? So start practicing that. It is a really important thing in getting a good history, good assessment, and building a rapport with the patient.
I have to say that in my environment, the first time I walked in with a chair, the patient said, I've never seen a physician sit down in my room. Something must be really going on. And I said, no, we're really here to, I had a trainee with me, a medical student, and I wanted to teach him how to do pain assessment. And I said, relax, it's just, we're just here to talk. And he said, I don't know. And then at the end, he said, you really were just here to talk? And I said, yes, we were just here to talk. So the first time you do it, you might find your patients to be startled that the doctor is sitting down.
Any other question, or should we move on to case presentation? I think it's 2 minutes past 4. So can we move on to the case presentation, Raju?
So today's case presentation will be taken by Dr. Reti Sutagaran. So over to you, doctor. Ma'am, can you unmute from your end? We are not able to.
Yeah.
Yes, doctor.
I'm muted now.
Yeah. Yes.
So, namaskaram. Hello.
Yes, ma'am. You can continue.
Are you hearing?
Yes, yes.
Yes, yes.
So I'm Dr. Rati Suthakaran. Actually, I'm not practicing as such. I'm actually working as a professor in the anatomy subject. So, but I'm trying to present this case. If there are some mistakes, please pardon me. Yes, yeah. I want to present this case of a 46-year-old male who is actually one of my neighbors who has got the problem, and his diagnosis was sepsis, upper gastrointestinal bleed, cirrhosis of liver with portal hypertension, carcinoma colon with metastasis. Next, please. This 46-year-old male presented with complaints of tarry stools, high-grade fever, and altered sensorium for the past 2 days. He was having loss of appetite and was not eating or drinking for a few days. And he was very weak and not able to stand up even. Next, please. Next. Next slide.
Ma'am, we have changed.
This patient was having loss of appetite for the past 1 month, and he was having high-grade fever and melena for the past 2 days. He took paracetamol tablets for the fever and kept quiet about the melena. Since 1 month, he was having intermittent colicky abdominal pain, nausea, and occasional vomiting, which is not associated with the food intake, for which he took some antacid tablets and antiemetics. He noted a loss of about 10 kg weight in the past 1 month. Then 2 years back, he had rectal bleeding following defecation, for which he consulted a local physician who made a diagnosis of hemorrhoids and advised diet control and supportive treatment. But with that, the symptoms were not relieved. It got worsened, but he did not tell his wife even. He was keeping everything as a secret. Noting yellowish discoloration of his eyes, his wife finally took him to a GI physician. Next slide, please. Next slide. Yeah. After the physical examination, this GI physician actually advised for the routine investigations, and the USG abdomen was done. Then he was diagnosed with the cirrhosis liver with portal hypertension. And he had a further undergone colonoscopy and the CT scan of abdomen. Colonoscopy revealed a sigmoid colon growth 38 centimeters from the anal verge. Biopsy was taken, and it was revealed moderately differentiated adenocarcinoma. CT scan abdomen confirmed the sigmoid colon growth. After preoperative evaluation, he underwent laparoscopic hemicolectomy. Intraoperatively, he had a minimal ascites sigmoid colon growth with minimal omental adhesions, and some peritoneal deposits were also found out in the right pelvic floor. Next slide.
Following the surgery, then chemotherapy was also given. Then 1 year after the surgery, he got hematemesis and was admitted to the hospital. Endoscopy was done and diagnosed with esophageal varices, which were banded. Then PET scan was done, then found out he was having metastasis. There were ill-defined hypoechoic hypo-enhancing lesions in the segment 6 of liver, and deposits were seen in L5 vertebra. Tiny nodules were seen in the right middle lobe of lung, and thus his findings were very serious, like suggestive of disease progression. Then his advice made him means that surgeons finally advised him to get the support from palliative care department, but this advice, the doctor's advice, made him hopeless. Family kept it as a secret, not even revealed or disclosed to his mother even, not even to the neighbors. Nobody, no friends, nobody were knowing. Next slide, please. These were the examinations showed that he was disoriented at this time, that pallor icterus was present, pedal edema was present, he was febrile, and his BP was 80/70. Then there was abdomen, the soft and non-tender abdomen that might help, mild help. Hepatomegaly was the shifting dullness, bowel sounds present, all this, and the CNS, CVS, and RS were within normal limit. Next, please. Then he was admitted to ICU with features of suggestive of septic shock and acute kidney injury. He was managed protectives, anti-coma regimen, albumin infusion, telepressin, and other conservative measures. For his upper GI bleed, he was ventilated, transfused with blood, stabilized, and urgent OGD was done. And OGD showed this grade 2 4-column varices with RCS and GOV2 with the active spurt. Even with medicines, his BP was fluctuating and he remained unconscious now. And doctors explained this poor prognosis of his illness to his wife and family. Next, please. Next. If his social status was considered, this patient was a high rank officer in a big firm, and he used to have in the sense he was about to conduct some meetings and parties and all, and he used to have alcohol in a regular basis. He was not a drunkard, like, and he was to attend parties, so he used to have it. And he was married about 18 years back, and he's having his 16-year-old son who is a 12th standard student. So he was undergoing university exams at this moment when he was hospitalized. And his mother is very healthy person. She is alive, about 75 years old. And at the end, now when this patient is in the ICU, she comes to know about his ill health. So finally, the family is of high socioeconomic status, but remained aloof from others. These are the medications which were given to him when he was hospitalized at the end stage. Next, please. So the main concern was that the BP continued to fluctuate. Patient remained disoriented. And next, yes. So this 46-year-old male presents with complaints of tarry stools, high-grade fever, and altered sensorium for these 2 days, and with loss of appetite, and finally he's seen that his BP is fluctuating and not having a good prognosis. Next, please. So the points which can be discussed is whether the details of this illness to be kept as a secret, what types of supports this family was in need, if there is a very poor prognosis for the disease. And if the patient is in the end stage of his life, whether he is to be kept in ICU, whether he is to be ventilated at this moment, if it is sure that his vitals are not going to function normally. Thank you.
Thank you, ma'am, for the presentation. I would like to hear from the participants your comments on these questions, these discussion points. Should we keep the details of illness as a secret? What do you think? I would like to hear from the participants.
We have to disclose the illness to the immediate relatives, not to everyone.
Yeah. Ma'am, your question was to keeping it as a secret from the relatives or from the patient or his wife and son, like the immediate family.
To disclose the matter to the immediate relatives and to tell to the patients, not all the things to the patient, but have to say he has some illness which we have to continue the medicines.
Dr. Rati, your question was specifically to tell about this illness to the patient and the family, or to everyone? Like, do you mean that they are not discussing it with anyone else, or do you mean that doctors are not telling this to the patient and the family?
No, doctors will be telling, but the patient and his immediate relative, means the wife and son only knows, but the mother is alive. Maybe that the mother is not to be disturbed, that is why he is keeping quiet. But then also he can tell his mother little bit, that because at the end when the mother is coming to know about this, so she is in intense pain, like it's a shock to her. So little bit of information is needed to the mother and the other family members. I feel so.
What do the other participants feel about it? Like, at least the immediate family members, do they want to discuss? What happens generally when people discuss about their cancer to the immediate family members? In your experience, do they take it well, or do they stigmatize, or do they try to give more sympathy?
Dr. Prema?
See, the patient is disoriented. So, discussing such serious thing at that moment, I don't know how much he'll be able to take it. But since he has a young son and is a young man, we have to consider also, he also has to, somebody close, maybe his wife. We don't know whether the wife, we could talk to the wife and find out about their relationship, and he has to settle things. So, some kind of an understanding with the family. Not the patient immediately, because what I've heard is the patient is disoriented. So we cannot talk to him at this point of life, the wife. But definitely, if he becomes lucid, then we have to also tell him the facts, because the prognosis is poor, and somehow prepare him. It will not take place immediately. I don't know. So since it is very serious in a short time, and they have strictly kept it very secret, it's a difficult case, really.
And Dr. Ann, what do you think about this concern? Should we keep it as a secret? How do people generally take when they, you have experience in both the countries, so how do people take when they share that they have advanced cancer?
Yes, so I think because I'm in Kerala and I don't speak Malayalam, it would be rare for me to break any collusion that might be happening here. But I agree with Dr. Prema that he is delirious, and we'll send you a paper about delirium. He would not be able to handle any of the details. He doesn't have capacity to understand what's going on with his illness at this moment. And then I typically ask the family what they want to know before I share the information. Sometimes I start with the immediate next of kin. This is a relatively young man. This is a shocking situation because he's so young. I would typically ask a family member what information they want and how do they want us to share information with other family members. At least in the US context, if the wife says we don't want the whole family to know about this, we would respect that because we assume she's talking in his best interest. So, so to answer the question, he cannot handle any details of his illness, and it is the wife. We need to talk to the wife, and I'm hoping that the wife will include his mother, who has to be very shocked that her young son, who should have quite a life ahead of him, is this ill. I hope that answers the question, Sridhar.
Yeah, thank you. And I think without the permission of either the patient or the wife, none of us or any professionals may not be able to access to his mother or any other immediate relatives. We need consent from their side. And many times people don't want to disclose due to n number of reasons, like they may think that the other person may not be able to handle it, or what if the relatives know and they come with a lot of sympathy and I look like a patient in front of them. So there are many issues that they discuss that they don't want to discuss it with any other family members and to keep it among themselves. And yes, it comes as a shock to all their family members. They may not have even heard about the cancer diagnosis. And what kind of support this family was in need? If just in case, if we had a chance to take care of the family, what all things would have been done for supporting this family? The first point which comes into my mind, I'm adding, I don't know how far the son knows about the illness. So the 16-year-old son will understand everything happening because of the advanced technologies, and they are so intelligent to keep a track of things. So I don't know whether someone has taken the effort to talk to the son. What does he understand, and what is that is one support that I feel that just comes suddenly into my mind. And is there anything else from the? There are more things, but I want to hear from the participants. What kind of support the family was? There is no right or wrong answer, so you need not worry that if I tell something wrong. These are all just real life scenarios. You cannot be right always. So we would like to hear from you so that we can also learn from you all. So we are not asking questions. We are inviting to participate for the discussion.
Dr. Anne Grace?
Yes, ma'am.
You had an answer, ma'am?
I couldn't hear the last few minutes well.
Yeah. We were just discussing about what kind of support this family may need. Even if you don't need to have an answer, but what do you think about it? What if it was your patient? What kind of support you want to extend to the family? He's a very young patient and with advanced illness and ended up in having a sepsis and other complications. What kind of support that this family might have needed?
I think, ma'am, mostly they want the emotional support because she's also very young and the son is young. And the presenter actually mentioned that like they are from high socioeconomic status, so the financial matter may be taken care of well, but the emotional support is the most important support I feel it's required.
Thank you, Dr. Rai. Thank you, Doctor. Anyone else on this question before we move on to the next?
Excuse me.
Yes, Dr.
Yes,
I
ma'am.
would I would like to share my experience. Very similar a history, very similar to this what is presented. One of my friends who lives in my apartment complex in Bangalore, she had a very similar experience. She was 40 year old and her husband was 46, and he had adenocarcinoma of colon, and he underwent several cycles of chemotherapy after surgery. And we being her first circle friends, we did not know about it for 2 years. They kept it as a secret. So what I felt was we came to know only when he was admitted uh, in the very terminally ill stage, and he was not brought back alive to the home. So at that last 10 days only we all came to know. So a very similar situation. We kind of this friend used to attend all monthly parties with us in a normal way. She never shared that the husband was. We all thought he's traveling abroad whenever he was admitted for gone for admission. So I think we might have to respect. If they want to keep it a secret, we should respect it because they are very well educated. They have they're financially like in good status. The son is also educated. He's working in the US, so they knew how to handle it. The mother of the patient was kept informed, but not in the loop for every single thing. So I think we should respect the family's expectations. We can discuss only through the person, the first line of relatives, and it is their wish whether to share it with others or not.
Thank you. It was
Thank you.
shared by Dr. Punita, right? I
Yeah.
can see everyone. Yeah. Thank you. Thank you for sharing. It sounds very similar situation.
Yeah, very similar.
Very similar. So
Now
yes.
that friend is back into our normal life, we can see her in last 2 month parties also. She's joining us very normally. In between, she didn't come for 2 months during the demise of the husband. After that, she's very normally back. So
Thank
that
you.
emotional support we needed.
Thank you. It's very important point to respect their privacy. If they don't want to disclose it to anyone else, that's that's their wish that we need to express. If the doctors are not informing the patient and family, that's a different affair. But if they want to keep it within them, that's. Can we move on to the third discussion point? Uh, is it needed when someone is in the end stage of an advanced illness? Do we really need to keep them in ICU, and does he need a ventilation if we are not sure how he's going to function after that? What do you think, other doctors? Is in this kind of prognosis when he has an advanced illness and he's reaching his end stage, should we need to take him to the ICU and to be ventilated? I think age is a very confusing factor here, because if this was an 85-year-old male with the same diagnosis and the same situation, we wouldn't have been thinking this much what would be right or wrong. Any comments on that? Or I would like to hear from Anne regarding the last two questions, although we'll be covering it in detail in end of life care, but we are just starting with palliative care concept. So what would you like to share from?
This is a very tough situation because I'm not sure why he's so sick. He's a 46-year-old with colon cancer, cirrhosis of the liver, and a fever. I don't know what the problem is, so I don't know if it can be turned around or not. Does he have ascending cholangitis? Does he have peritonitis without pain in his abdomen? I would feel different. So I don't know, Dr. Sridevi, what you were expecting me to say, but in this case, I don't know if he is simply septic and we can turn his life around temporarily with antibiotics and treatment and give him some more months of life, or whether he's in his active recurring process. I simply can't tell without knowing more. So I can only speak from my experience in the US. This patient might be in the ICU for a short trial of antibiotics to see if he can get better. But we have ongoing conversations with his wife, support his son, talk to his, if his wife agrees, and talk to the mother if the wife agrees. That's the way we would handle it, is maybe do a short term because we don't know where this fever and infection is coming from. So we might do a trial of antibiotics. On the other hand, if we think he's end stage colon, person with colon cancer, we typically do not keep those patients in the ICU. It's just, this one was a tough one for me to answer questions 3 and 4 for that reason.
Yeah, I understand, because we don't have much details, and obviously I understand they didn't want to discuss it with anyone else, and this might be the findings that he might have received. But there is no right or yes or no answer to all these scenarios. We don't know whether there was something reversible, which are the things which were irreversible. I think only the family members and the treating doctor might be knowing much more about it, like why this has gone bad. Was it a reversible or irreversible condition? But I think whatever may be the situation, the biggest support the family may need is the proper, honest conversation about what is happening inside the ICU, how the son is taking it, because she was mentioning he's undergoing going to face his university exams. So how he's coping with this, how the wife is coping. Is there any areas of ambiguity in terms of we don't know what is happening, the person is inside? So the support needs in that way, where they need the information, they need the clear information, and we are not sure whether they had the information and they didn't want to share. But yes, there is no yes or no answer for the last 2 questions.
That's correct.
Yeah, that's a really tough decision to make.
Before we go, can I just make an important point that the other very important symptom that this patient has is delirium. I'm hoping that we'll send along an article about delirium. We need to not say, oh, patients are always have delirium in the ICU. We need to treat that very aggressively, because it takes a long time for people to recover from delirium once it sets in. So I just wanted to alert people that this is not normal for people to be delirious when they're in the hospital. So
ಅಂತ ಬರ್ದಿದ್ದೀರಾ, ಇವಾಗೇನ್ ಮುಟ್ಟು ಮಾಡ್ಸಿ ಅಂತ ಹೇಳಿದ್ರೆ ಮಾಡ್ಸಿ.
So, alrighty, we'll send that article along too.
And we will have a detailed session on delirium.
Great.
So, any more questions regarding this patient story coming up?
There are no hands raising up, then we'll conclude today's session. No, we have 4:30. I would like to thank to come up with a case presentation, Dr. Rati, although she's not in practice, but she managed to get all the details from her neighbor, and taking up the case presentation in the first trial is really something appreciable. So thank you so much for bringing up the scenario for discussion, and it was a good scenario to discuss. And thank you so much, everyone, to be a part of the session. And thank you, Dr. Ann, we could hear from you.
Okay. All right. Bye-bye, everybody.
Raju, about the feedback, if you want to.
So I have shared the feedback link in the chat. So give it a minute, do it. So we will not be having any sessions on the upcoming 2 weeks. Like we are having a conference in palliative care coming on next Friday, and we will be having Mahashivaratri coming the next week, 21st. So we will be having only session on 28th now. Please make it a point and only log in at 28th. So thank you all for joining in. We will see you on 28th. Bye.